Welcome to this CME CE certified activity titled Integrating the Latest Advances into Clinical Practice, Data and Expert Insights from the 2016 Meeting on Gastrointestinal Cancers in San Francisco. This educational activity is jointly provided by the Postgraduate Institute for Medicine and Access Medical Education and is supported by educational grants from Novartis Pharmaceuticals, Taiho Oncology Incorporated, and Lilly. My name is Dr. Pamela Kunz, Assistant Professor of Medical Oncology at Stanford University School of Medicine in California. My disclosures include consulting fees for Ipsen, Lexicon, and Novartis, and contracted research for advanced accelerator applications, SNX, Genentech, Lexicon, Merck, Novartis, and Oxygen. Our discussion today will include the most exciting and compelling data in pancreatic adenocarcinoma, pancreatic neuroendocrine tumors, and GI neuroendocrine tumors from the 2016 GI Cancers meeting and insights on how these clinical advances may be practice-changing. So let's begin. The first study I'd like to highlight is Abstract 194 by Dr. John Strasberg and colleagues on the NETTER-1 study, a phase 3 trial in patients with midgut neuroendocrine tumors treated with lutetium-177 dotatate. So the background of this study is that limited tumor control options for patients with midgut or small bowel NETs exist beyond first-line somatostatin analogs. PRRT, or peptide receptor radionuclide therapy, has long been available in Europe, yet the data demonstrating its efficacy have all been retrospective in nature. So this study, highlighted in this abstract and subsequently a presentation, NETTER-1 is the first phase 3 multicentric randomized controlled trial evaluating 177 lutetium dotatate in patients with inoperable, progressive, somatostatin receptor positive midgut NETs. So in this study, 230 patients with grade 1 or 2 metastatic midgut NETs were randomized to receive either lutetium-177 dotatate every 8 weeks, and that was 4 administrations, versus high-dose octreotide at 60 milligrams every 4 weeks. Their primary endpoint was progression-free survival per RECIST 1.1 with objective tumor assessments performed by an independent central reviewer every 12 weeks. The secondary objectives included response rate, overall survival, toxicity, and health-related quality of life. So 230 patients were randomized 1-to-1 across multiple centers in Europe and the U.S. The median progression-free survival was actually not reached for the experimental arm of lutetium-177 dotatate and was 8.4 months in the high-dose octreotide arm. This was with a hazard ratio of 0.21 that was statistically significant with a p-value of less than 0.0001. The number of complete responses plus partial responses was 19 for an 18% response rate in the lutetium-177 dotatate group and only 3% in the octreotide LAR group. The overall survival data were not mature enough for definitive analysis. However, there was a trend favoring the lutetium-177 dotatate arm. So in conclusion, this phase 3 NETTER-1 study provides evidence for clinically meaningful and statistically significant increase in progression-free survival and objective response rate. There is a suggestion and only a trend in overall survival. This is likely to be practice-changing, and though it is currently available in Europe, we anticipate that this will be submitted for FDA approval in the U.S. There is a video of a presentation on this abstract available on the GI ASCO website. So the second abstract I'd like to discuss is 195 by Dr. Lee, a PD-1 blockade in mismatch repair deficient non-colorectal GI cancers. So mismatch repair deficient tumors harbor hundreds to thousands of mutations that may produce neoantigens that can be recognized and targeted by T cells. Mismatch repair deficiency can serve as a predictive biomarker for tumors across multiple histologies that may actually respond to immunotherapy, specifically PD-1 or programmed death 1 blockade, like pembrolizumab, which is an anti-PD-1 targeted agent. Mismatch repair deficiency is present in about 15% of colorectal cancers, and early efficacy of pembrolizumab has already been demonstrated in these MSI-high colorectal cancers. MMR deficiency is also detected in non-colorectal cancers in 2 to 20% of gastric, small bowel, and hepatobiliary cancers, and this study examines that population. So this was a phase 2 study to evaluate anti-PD-1 pembrolizumab in patients with previously treated progressive advanced cancers. 21 patients were enrolled onto the non-colorectal cohort. The pembrolizumab dose was 10 milligrams per kilogram IV every 2 weeks. Primary endpoints were objective response rate. Secondary endpoints included PFS and overall survival. And in 17 patients with non-colorectal GI cancers, including ampullary, pancreas, biliary, small bowel, and gastric, only 10 patients were evaluable at the time of abstract admission. However, 50% had an objective response rate, so 5 out of 10. The disease control rate was 70%, so 7 out of 10. Overall survival was 21 months, and the median duration of response ranged between 5 and 17 months. The median follow-up was 7 months. So, though this study is very small and really still preliminary in its results, PD-1 blockade does show promising activity in mismatch repair non-colorectal GI cancers. This is really the first study to evaluate that population. A video presentation of this abstract is also available on the GI ASCO website. The third abstract I'd like to discuss is number 315 by Dr. Singh and colleagues, and this examines the efficacy and safety of everolimus in advanced progressive non-functional NETs of the GI tract and unknown primary. So it's actually a subgroup analysis of the phase 3 RADIANT-4 trial. So a series of RADIANT studies have been performed examining the efficacy of everolimus in NETs. I'll just remind you that the RADIANT-2 study was a phase 3 study of GI, pancreatic, and lung NETs. It was a negative study, and it was thought to be negative due to a fact called informative censoring, because both central review and local radiology review were performed. The central review was not performed in real time, and that thus introduced bias into the results. It was just barely negative in terms of its statistical significance. The RADIANT-3 study was also a phase 3 study only in pancreatic NETs. It was a positive study and demonstrated benefit of the everolimus arm with a progression-free survival of 11 months versus 4.6 months with a hazard ratio of 0.35. The third phase 3 study in the series was RADIANT-4. It examined GI and lung NETs and was a positive study favoring the everolimus arm over placebo with a progression-free survival of 11 months versus 3.9 months and a hazard ratio of 0.48. This was just published in the Lancet in December of 2015. So in this study, we're going to focus on a subset analysis of the RADIANT-4 trial. I'll remind you that 300 patients with advanced, progressive, well-differentiated, non-functional GI or lung NETs were randomized in this study 2-to-1 to everolimus versus placebo. And the results of this study, 175 had GI NETs and 36 patients had NETs of unknown primary. In the GI NET patients, the median age was 63, 55% females, 75% grade 1 tumors, and similar baseline characteristics were seen in the patients with NETs of unknown primary. In patients with the GI NETs, the median PFS was 13.1 months versus 5.4 months with placebo, with an estimated 44% risk reduction in favor of everolimus, so this was significant. And in patients with NETs of unknown primary, the median PFS was 13.6 months versus 7.5 in placebo, And of note, this actually was not statistically significant, though there was a trend towards favoring the everolimus arm. I should say that both of these subset analyses were pre-planned as part of the study. So this analysis demonstrates improvement in PFS for patients with GI NETs in that subgroup and suggests efficacy in the NETs of unknown primary, though not statistically significant. And the safety profile is consistent with that previously reported. I'd like to finish up the discussion with a couple of general comments, and I've grouped a few abstracts just to really bring out a few themes. So abstracts 395 and 312 both discuss modified FOLFIRINOX. So the goal is to really mention this role of the modification since the original publication by Conroy in 2011. So in that study, FOLFIRINOX was demonstrated superior to gemcitabine in the treatment of metastatic pancreatic adenocarcinoma, with an overall survival favoring the FOLFIRINOX arm of 11 months versus 6.8 months with a hazard ratio of 0.57. A pre-PFS benefit as well, 6.4 versus 3.3 months, and a response rate benefit, 32 versus 9%. However, the dose intensity of the study was only about 80% due to required dose reductions for toxicity. So thus it prompted many oncologists to use modifications in practice despite the absence of prospective data validating this comparable efficacy and improved tolerability. So both of these studies went on to examine modified FOLFIRINOX. So briefly, the abstract 395 by Stein examined a phase 2 study of modified FOLFIRINOX in locally advanced and metastatic pancreatic cancer. It was really the first prospective study using modified FOLFIRINOX in this group. Patients received irinotecan and bolus 5-FU at 25% dose reductions compared to the original published study. They also received pegfilgrastim as supportive therapy. A total of 75 patients were enrolled. The regimen was well tolerated. And in metastatic pancreatic cancer, the response rate was 35%, progression-free survival 6.1 months, and overall survival 10.2 months. And in locally advanced pancreatic cancer, the response rate was 17%, PFS 17.8 months, and overall survival 26 months. So in metastatic pancreatic cancer patients, the efficacy really appeared uncompromised. And in this first study of modified FOLFIRINOX in locally advanced pancreatic cancer, the PFS and overall survival are very encouraging. In the second partner study, abstract 312 by Marsh and colleagues, this was a perioperative modified FOLFIRINOX in resectable pancreatic cancer. In this study, phase 2 study, patients received 4 preoperative doses of FOLFIRINOX and 4 postoperative cycles of FOLFIRINOX. The only modification compared to the original published regimen was that the bolus 5-FU was omitted, and pegfilgrastim was also included in supportive care. 17 of 21 patients completed neoadjuvant FOLFIRINOX, and 14 of 21 completed all planned therapy. Radiographic responses were rare, but the R0 resection rate was quite high, 94%, so 16 of 17 patients in those undergoing resection, and the safety was as expected. So I think these are intended to be provocative. They're not definitive. They're not large studies, but I think starting to introduce this concept of modifying FOLFIRINOX in favor of a safer, less toxic regimen and really evaluating its efficacy. So lastly, I'd like to talk about another theme, a novel agent in pancreatic adenocarcinoma. So this is looking at a stem cell inhibitor, BBI-608, so in 2 studies. So abstract 284 by Dr. Shada and colleagues, a phase 1b study of BBI-608 in combination with gem-nab-paclitaxel in patients with metastatic pancreatic ductal adenocarcinoma. And a second study, Abstract 196 by Dr. Bakai-Saab, a phase 1b/2 study of BBI-608 combined with weekly paclitaxel in advanced pancreatic cancer. So the goal in grouping these studies is to mention the role of this first-in-class cancer stemness inhibitor, BBI-608, in metastatic pancreatic adenocarcinoma plus chemotherapy. Cancer stemness is really thought to be associated with resistance to chemotherapies, thus the interest in combination therapies. So in the first abstract, 284, this was phase 1b plus gemnab paclitaxel. Its purpose was to determine the randomized phase 2 dose. Patients were treated with BBI-608, 240 milligrams twice daily, plus gemnab paclitaxel at standard doses. 31 patients were enrolled. 80% were actually treatment naive, and only 20% had received one prior line of therapy. It was very well tolerated. The most common adverse events included diarrhea, abdominal pain, nausea, and fatigue, and it had promising efficacy. So of the 7 patients evaluable for efficacy, the disease control rate was 100%. So 7 out of 7 patients had either stable disease or partial responses. Tumor regression was seen in 6 out of 7 patients, and median PFS was 7.8 months. In the second partnered abstract, number 196 by Dr. Bakai-Saab, this was a phase 1b/2 study of BBI-608 plus paclitaxel in patients with heavily pretreated metastatic pancreatic adenocarcinoma. So patients were treated with BBI-608 at 480 milligrams or 500 milligrams BID, so note the difference in dosing compared to the prior study, in combination with paclitaxel. 41 patients were enrolled, had received a median of 2 prior lines of therapy, so much more heavily pretreated than that prior abstract. It was also well tolerated. Most common AEs included diarrhea, abdominal pain, and nausea, and also showed promising activity with a response rate of 7%, disease control rate of 52%, median progression-free survival of 10 weeks, and median overall survival of 24 weeks. And these data were better in the taxane-naive patients. So we will conclude with that abstract. I will make just a few concluding remarks. So abstract 194 of the NETTER-1 study demonstrated that PRRT prolongs progression-free survival compared to octreotide LAR in midgut nets. It's the first agent in small bowel nets with an increased response rate. There's also a trend towards improvement in overall survival, and it was deemed to be safe. Abstract 195 of a PD-1 inhibitor, pembrolizumab, demonstrates promising activity in MSI-high non-colorectal GI cancers. Abstract 315, the RADIANT-4 subset analysis, showed that the efficacy was maintained in a subset of GI nets and a trend towards maintaining that efficacy in unknown primaries. Abstracts 395 and 312 demonstrated that modified FOLFIRINOX was safe, and the efficacy appeared to be unchanged compared to the Conroy regimen in metastatic pancreatic adeno and encouraging efficacy in locally advanced. And then abstracts 284 and 196 showed a novel first-in-class stem cell inhibitor demonstrating that combination therapy is safe and has promising efficacy. With that, we'll conclude this activity. So thank you so much for your participation today.